So welcome everybody. This is Dr. Septi. I want to welcome everybody here at Hackensack University Medical Center, as well as all the doctors that are listening to us from Hackensack University, UMC at Mountainside, Hackensack UMC at Palisade, as well as Jersey Shore Medical Center, at Meridian Health, and Inglewood Hospital. We also welcome everybody that is online following this course. Today we have a great speaker. We have two parts today. The first part is hematology. The second part is oncology. I would like to welcome today Dr. Stefan Federal, who is the Chief of Leukemia, a great doctor and researcher, and he's going to use the first part to teach us about hematology. Dr. Federal.
So thank you for the introduction, and good evening, everyone. Before we get started, I think this is my disclosure and information slide. I have nothing to disclose with regard to my presentation tonight. So I will spend the first 2 hours talking about hematology. I'd like to be systematic, so I kind of divide the hematology part in the benign hematology, which isn't always that benign, and a smaller part into malignant hematology, and I have divided all the groupings in certain themes. So my first big theme in hematology is anemia. Anemia is defined simply as a decrease in the mass of red blood cells. In male persons, less than 14 grams per deciliter is hemoglobin. In females, a little bit lower. Certainly the androgens have some erythropoietic effect, accounting for some of the differences between the genders. This decrease in red blood cell mass leads to insufficient transport of erythrocytes and oxygen with it to tissues, leading then to the pathologic manifestations of anemia. The etiology of anemia is actually fairly simple. You may lose blood. That's easy to obviously discern and diagnose. You may underproduce, or you may destroy blood cells in the circulation. The manifestations of anemia are manifold. They may be, for most patients, be very non-specific, as shown here on the slide. Actually, in quite a few patients, they may not have many symptoms at all if the anemia is mild and otherwise well compensated. There are certain manifestations that give you some pointers as to the etiology, such as a big spleen or being jaundiced, may point towards a hemolytic form of anemia. Neurological abnormalities may point towards a megaloblastic form of anemias, and so on. Laboratory diagnosis is obviously based on your CBC with a differential count that gives you information also about the red blood cell indices, like the size and shape of the red blood cells, as well as the distribution of size in the red blood cell distribution width. The reticulocyte count index gives you some idea about the activity state of the bone marrow and the state of erythropoiesis in general. And last not least, you will look at the peripheral smear, which can give you some ideas and hints and information based on the morphology that you may detect. And this slide shows some examples of various etiologies of anemia that just here put together without much of a system. We see schistocytes in the left upper slide. These are types of red cell changes you'll see in micro or macroangiopathic mechanical forms of hemolytic anemia. The next slide to it shows sort of a microcytic hypochromic picture, as you may see in, for instance, iron deficiency anemias. Spur cells on the next slide, abnormally shaped red blood cells with those spikes on their top. In this case, it may indicate, for instance, severe liver disease. You have similar changes, for instance, in renal and kidney disease and other medical conditions. Rouleau formation is agglutination of red blood cells, a change that's quite typical, not specific, but nevertheless typical for instance, multiple myeloma. Obviously, the typical sickle cell changes you see in sickle cell anemia. In megaloblastic anemias like B12 or folate, picture is very identical. You see larger red blood cells with hypersegmented neutrophils that have at least 5 or more divisions. Nucleated red blood cells give a general idea about a stress state of the marrow, marrow infiltration or other processes affecting the bone marrow space. So you can pick up a lot of things if you look at the peripheral blood smear. So one systematic approach to anemias is to divide them into overproduction anemias and underproduction anemias. And one way to do this is based on the reticulocyte index. What you get here from the CBC, don't get it from the CBC, you have to order it separately, but you got here is a reticulocyte percentage. That's not a very accurate measure. The least awkward way of assessing reticulocytes is actually the total absolute number, which is done by flow. A normal count is somewhere between 30 and 95,000 per microliter. And anything above, say, 110,000 per microliter is a very good indication of a hyper-overproductive state of the bone marrow. The reticulocyte index is sort of a composite calculation of your reticulocyte percentage, taking into account the hematocrit. You can calculate it through various calculation tools on Google or UpToDate or similar websites. Reticulocyte is a very immature form of a red blood cell. It's larger than the red blood cell. It's called reticulocytes because they contain a reticular net-like looking structure of ribosomes in their cytoplasm. So based on a low reticulocyte index versus a high index, you can divide into underproduction versus overproduction anemias. Within the hypoproliferative section, then you use the MCV, MCH to distinguish further into microcytic, macrocytic versus normocytic. On the overproduction side, besides blood loss, which I'll not obviously go into, it's not a hematology problem really, you have the big group of hemolytic anemias, which I will address separately a little bit later. So let me start with the hyperproliferative anemias. The most important ones to memorize are iron deficiency, B12 folate deficiency, anemia of inflammation or chronic disease that it used to be called, and anemia in association with kidney disease. Now, by far the most common type of anemia is probably iron deficiency anemia. Iron is required for production and maturation of red blood cells. It's absorbed in the proximal small bowel. The best source is heme iron contained in red meat, fish, poultry. You also find non-heme iron in vegetable sources, but they're not as easily absorbable because they tend to be chelated by other molecules such as phytates and oxalates. Iron is regulated by a number of other proteins. One of the most important is probably hepcidin. That's a major regulation of iron homeostasis, which itself interacts with iron transport proteins on enterocytes in the bowels and macrophages, or cells of the reticular endothelial system. This is a molecule for which no commercial test exists, so you will never ask for it, at least not as of today, and you will not get it. But remember, nevertheless, in iron deficiency anemia, hepcidin levels are typically low. They would be low. Etiology of iron deficiency, you have certain high demand states in pregnancy. If you give erythropoietin stimulating agents like Procrit or darbepoetin. Also in children and infants, they are more likely to become iron deficient simply because they need more than the average adult person. Outside this, you find it in several malabsorptive states that interfere with absorption in the proximal small bowel. A very, very important consideration in any adult, especially male patients with iron deficiency, is, however, to exclude GI malignancies because this will be the most common and important source of chronic blood loss. Manifestations of iron deficiency are those of anemia in general, fatigue, tiredness, weakness. There are a few, maybe a little bit more specific type of manifestations affecting mucous membranes and skin. Some patients have a desire to take crunchy materials. It may be anything listed here, ice, clay, starch, whatever it is. And you may find nail changes in iron deficiency, which may not be so common in anemias of different etiologies. How do you diagnose it? Obviously, the iron level is going to be low, but that's one of your least specific findings, ironically. The total iron binding capacity level will be high. Both of those you will get with an iron panel. Out of the ratio of iron level and TIBC, you get the transferrin saturation. That's also already given calculated. If it wasn't, you could just do it yourself. And in iron deficiency, it's typically very low. Less than 10 to 15% transferrin saturation is very indicative of iron deficiency. Actually, the most efficient test for iron deficiency is ferritin. It's an iron storage protein, especially if it is very low, less than 10 to 15 nanograms per ml. The problem with ferritin is it's an acute phase reactant, so any inflammatory, infectious, or otherwise inflammatory state might just increase the ferritin. However, a ferritin higher than 100, regardless of what other inflammatory state may be the case, is hardly compatible with iron deficiency. Soluble transferrin receptor is not a test you would typically order or look at or get. It's a test of a quantitative measure of the erythropoietic state of the bone marrow. It directly correlates to the erythropoietic activity and indirectly correlates to the tissue iron content. It helps most in the distinction between iron deficiency and anemia of inflammation or chronic disease. Hepcidin, I mentioned it, is a very important regulatory protein. Again, no commercial test, so you won't find it in clinical practice, but you might well be asked. Hepcidin levels are low because the body wants to release iron. It wants to absorb iron from the enterocytes. It wants to release iron from macrophages or RAS cells if you have a truly iron deficient state. Also, thrombocytosis is not so uncommon. We'll get to this later in terms of the other etiologies, but iron deficiencies are very important and quite frequent reason for reactive, in this case, it's not clonal, obviously reactive thrombocytosis. Treatment is actually fairly simple. Iron replacement, the most efficient or least expensive way is oral iron replacement. Mostly you would use ferrous sulfate. It actually doesn't contain that much iron and the absorption rate is even lower. You can increase the absorption in an acidic environment. Vice versa, if you take antacids or antibiotics or some food like dietary fiber, cereals for instance, or tea and coffee, the absorption will be significantly decreased. Also, if you take slow release preparations, which may be better tolerated, but they may pass the proximal small bowel absorption site, so it may just get lost. Main side effects with ferrous sulfate or oral iron supplementation are GI, nausea, constipation, bloating, discomfort. So actually a lot of people don't like it, they can't continue doing it. Ferrous gluconate is oftentimes better tolerated, but if oral iron supplementation just doesn't work, you use intravenous preparations of iron. The main concern with intravenous iron preparations has always been anaphylactic reactions. They're actually quite infrequent with the current preparations, even more so. So for most patients, this is not going to be an issue, but it's a more expensive way of doing it, and patients have to come to the clinic. They have to sit there for up to 6 hours, depending on what sort of preparation you use. So oral is easier, but for patients who cannot tolerate it, then you have no choice. So this is iron deficiency anemia. The next big group are macrocytic anemias, simply descriptively anemias with larger red blood cells as opposed to microcytic. A good way to distinguish, again, here is between megaloblastic and non-megaloblastic. Megaloblastic indicates a dyssynchrony in the maturation between cytoplasm and nucleus because of an impaired DNA synthesis that then leads to ineffective erythropoiesis, and the two major causes is folate and B12 deficiency. Now, red blood cells can be big for other reasons that have nothing to do primarily with impairment of DNA synthesis. And there's a number of possibilities: liver disease, alcoholism. A lot of reticulocytes in the circulation make it macrocytic because these are larger, immature red blood cells. Hypothyroidism is something to think about if you kind of go down your differential, especially in older patients with macrocytic hyperchromic indices. You always want to think about possibility of myelodysplastic syndrome. There's also medications that kind of lead to this picture and some metabolic disorders. So the two important ones here, B12 and folate. I will start with vitamin B12 deficiency, necessary also for DNA synthesis. B12 is not, humans cannot synthesize B12 intrinsically, so we are dependent on uptake through our diet, and that's really only found in animal meats and not in vegetable sources. So in the gastric environment of the stomach, cobalamin or B12 is released from the food, and then transferred to so-called R binders, and this R binder B12 complex, then a little bit lower down in the alkaline environment of the small bowels, is connected to the so-called intrinsic factor, and this complex then is being absorbed in the distal part of the small bowel, the ileum, as opposed to iron, which happens in the proximal small bowel. There are large storages of vitamin B12 in liver cells, so even if you stop taking B12 now, you probably wouldn't have any signs or symptoms or manifestations until like 2 to 3 years when you exhaust the iron stores. So the etiology for vitamin B12 deficiency, in most cases, it's some form of malabsorption that affects the ileum, be this inflammatory bowel disease, celiac disease, or other causes. Pernicious anemia is an autoimmune type disorder in which antibodies are being produced against parietal cells or intrinsic factor itself, sometimes associated with other endocrine manifestations. And there is some a little bit disputed, not that well established association with an increased risk of gastric cancer. Malnutrition for B12 deficiency does not play such a huge role, partly because of the iron stores, the B12 stores in the liver as well. So what are the manifestations? Obviously, you have anemia, ineffective erythropoiesis. You have a hemolytic anemia that plays itself out in the marrow space, actually, not in the circulation. And importantly, associate with vitamin B12 deficiency the possibility of neurologic deficits or manifestations. These neurologic deficits may take two forms. It may be a sensory deficit, mainly position vibratory sense, or a more global encephalopathic feature characterized by hallucinations, psychosis, sometimes in literature referred to as megaloblastic mania. This sort of neurological picture you actually also find in copper deficiency. Gives a very similar picture in that sense compared to B12 deficiency. On the blood smear, you see the macrocytic changes, so-called oval macrocytes, basophilic stippling if you pick it up, but very distinguishing is or are hypersegmented neutrophils. So neutrophils that have more than 5 lobes. You would expect 3 to 4, 5 at most lobes. More than 5 lobes in neutrophils, like shown on this picture here, is very typical for B12 deficiency. How do you diagnose it? Well, you look at serum vitamin B12 levels, fairly easy. You may have signs of hemolysis, low haptoglobin, increased LDH, increased indirect bilirubin. So these 3 changes are very non-specific for any sort of hemolysis of whatever etiology. If you deal with pernicious anemia, may not be common, but nevertheless, you ask for anti-intrinsic factor or parietal cell antibodies. Nobody does the Schilling test anymore. And you can also, especially in patients with low normal B12 levels, they may still be B12 deficient. Under those circumstances, it may be helpful to look at some of the metabolites that depend on B12, like methylmalonic acid and homocysteine. Both of those get processed with the help of vitamin B12. If B12 is missing, they just back up and they have increased levels. And you have both together increased methylmalonic acid and homocysteine. How do you treat it? You supplement. Historically, you would use parenteral vitamin B12. It's very efficient to do so. However, more recently, it's also been shown and demonstrated that oral replacement therapy is just as good and much cheaper. 1 or 2 milligrams orally daily leads to the same sort of recovery and resolution of the changes of B12 deficiency. And on your slides, I've sort of kind of shown how they change over the first few days into the next few months. It's easier to correct the hematologic manifestations. Once you have established neurologic deficits, then it takes longer for improvement. If it happens at all, it depends on how far into patients were diagnosed. Folate deficiency is in many respects actually very similar to B12 deficiency. It's rare because the regular diet is replete with folate. It's really hard to miss out on folate. Compared to B12, the body does not contain anywhere close to the storage capacity for folate than it does for vitamin B12. So after 2-3 months of not taking folate, as hard as it may be, you're going to run out of it. In terms of etiology, for folate deficiency, malabsorption maybe is not so important. Here you find it more in connection with malnutrition and alcoholism, anorexia, and elderly patients that have very restricted diet, your tea and toast diet, whatever it may be. The other causes here listed on the slide, not so frequently. The manifestations are identical essentially to B12 deficiency, the clinical manifestations. So you have the same morphologic changes in your peripheral smear. You have the same sort of macrocytic hyperchromic changes. You look for serum folate. That's not very reliable. It's better to look at red blood cell folate levels. Folate too metabolizes homocysteine, as does vitamin B12. So if folate is missing, homocysteine is backing up, so you will have high homocysteine levels. But folate is not relevant for the metabolism of methylmalonic acid. So if only folate deficiency, methylmalonic acid will be metabolized properly and will not be elevated. So that's a major difference if you look at those two metabolites between B12 and folate deficiency. In B12 deficiency, both methylmalonic acid and homocysteine will be elevated. In folate deficiency, it's only homocysteine. So if you wonder, you can kind of use this as a distinction. The treatment is very simple. It's just folate supplementation orally. If you do, you may want to exclude and make sure that you're not dealing with some sort of B12 deficiency. For a simple reason, folate is very good to alleviate the manifestations of the hematologic manifestations of B12 deficiency, but not the neurological manifestations. You actually may exacerbate those. So the next group is anemia of inflammation or chronic disease, as it's been known in the past a little bit more frequently. There's many inflammatory states you can think of. Obviously, chronic infections, prime examples are sort of TB, osteomyelitis, malignancies, collagen vascular diseases, HIV, which can do almost anything anyway. But also think of more chronic medical conditions, which you may not always associate with inflammatory states, but inflammation probably plays a substantial role in it. For instance, diabetes or chronic congestive heart failure. The two major pathophysiological branches in anemia of inflammation is a blunted response of erythropoietic precursors to erythropoietin itself, partly because the erythropoietin production goes down, partly because those erythropoietic precursors in the bone marrow are just not as responsive to it. So that's one part which matters. The other one is the increased level of inflammatory cytokines. There's many different forms of interleukins, interferons. In particular, interleukin-6 is being associated with lots of inflammatory conditions and it plays a role here as well. So decreased response to erythropoietin for the reasons as stated, and impaired iron utilization are the two major factors that play into anemia of inflammation. In this case, you have actually an upregulation of hepcidin, as opposed to the low levels you would find in anemia of iron deficiency. Usually anemia of inflammation is normocytic, but if it goes on for a while, it can change into a microcytic type picture. The hemoglobin usually more than 8, but that's not a very helpful distinguishing feature to iron deficiency. The reticulocyte count typically low because of the decreased erythropoietic activity in the bone marrow. Iron may be normal to low and completely indistinguishable from iron deficiency anemia. The major distinctive factor is that in inflammatory anemias, you have a high or elevated ferritin. No matter how high it is, it's certainly not very low, like less than 10 or 15. And the total iron binding capacity is low. In iron deficiency, it's high. So these two tests are useful to distinguish, but not the iron level or the level of anemia or the shape of the red blood cell. A lot of patients may not even need treatment. Iron replacement may not be helpful, partly because the body just can't utilize that much iron. There's always exceptions to the rule. If you have substantially low levels of iron saturation or the ferritin levels, you may kind of use iron to a point. Erythropoietin stimulating agents are a possibility. The concern here is if you push too hard on an increase in hemoglobin, you may run the risk of other adverse events that come with it, and the two major ones is hypertension and thromboembolic complications. So if you kind of use erythropoietic stimulating agents, the hemoglobin really should not ever exceed 12 grams per deciliter. Actually, a lot of people are very uncomfortable to give it for hemoglobin levels of 10 and higher. Anemia of kidney disease is a little bit different from chronic inflammation. It's usually normocytic and not microcytic. If you find microcytic changes developing in patients on dialysis, for instance, you may really worry and wonder about a possible blood loss from GI sources. You find some particular abnormalities on the smear, which I showed you in the second slide, so that it looks similar to the Burr cells, but they're not quite the same. You may use erythropoietin stimulating agents, which you do routinely anyway, same cautions as on the previous slide, and you may need iron for those patients. So erythropoietic stimulating agents and iron levels, maintain good iron levels, are important in anemia of kidney disease. So this table compares those major conditions, inflammatory anemias and iron deficiency anemia. The major distinction, again, I'm repeating myself, but it's probably the important part for the boards, is a low TIBC level in inflammatory, high in iron deficiency, and a low level of ferritin in iron deficiency versus a higher ferritin level. Right, so this was the hypoproliferative anemias. Now let's switch on to hyperproliferative overproduction anemias. And if we leave aside blood loss, which I'll do, then we are really talking about hemolytic anemias. That's a very large group of diverse diseases. They all share one common denominator at least, and this is accelerated red blood cell destruction from whatever source that is. So that's the smallest common denominator for hemolytic anemias. One good way, I think, to orient yourself through the many different types of hemolytic anemias is to divide them into intrinsic forms that relate to some sort of structure, the red blood cell itself, versus extrinsic forms. Among the intrinsic forms, there's actually a good correlation between this division, intrinsic, extrinsic, and the mode of inheritance. So in that intrinsic hemolytic anemias almost always are hereditary, with one exception, which I'll touch upon later. This is paroxysmal nocturnal hemoglobinuria. And the extrinsic ones correlate very well with acquired. There's always a little bit of a mishmash in that hereditary hemolytic anemias may be well compensated and mild, so you may not even diagnose it until adulthood, and it sort of looks like acquired, but it's not really. Among the intrinsic ones, you should memorize 3 major possible defects and 1 or at most 2 examples for each one of them. So you can go wrong with some enzymes in the red blood cell, and the prime example is G6PD deficiency. You can have defects on the membrane of red blood cells, and a good example here is hereditary spherocytosis, or you can have defects in the hemoglobin chains themselves. And the 2 major examples here are thalassemias, obviously, and sickle cell anemia. And I think that's all you need for the boards to kind of cover the intrinsic hemolytic anemias. On the extrinsic side, your most important distinction is between immune-related hemolytic anemias, autoimmune hemolytic anemias, and the whole bunch of non-autoimmune hemolytic anemias. And among the latter, the non-immune hemolytic anemias, what you clinically need to know is microangiopathic hemolytic anemias, because that means TTP and HUS and all the good stuff that comes with it. So this is an overview how you kind of may approach the hemolytic anemias. Otherwise, it's a huge amount of kind of all different diseases. Now, how do they manifest themselves? Yes, you have signs and symptoms of anemia, fine. More specifically, you here find manifestations of the breakdown of blood cells in terms of increases of bilirubin, gives you icterus, propensity to develop gallstones. Not infrequently, those patients have extravascular hemolysis, which means a big spleen. It's helpful to look into the family history for those type of conditions that give some pointers. Typically, in these hyperproliferative anemias, the reticulous count is high because the marrow tries to make up for the destruction of blood cells in the periphery, unless there are concomitant conditions that suppress the marrow, which is not a good combination. At the bottom of the slides, I kind of showed you some examples for this. Patients may be hemolyzing and at the same time have folate deficiency, or deal with some infection, or this parvovirus B19 infecting erythropoietic progenitors. There are very common lab manifestations of hemolysis, LDH elevated, heptoglobin low, indirect bilirubin up, and that's sort of something you sort of have to rattle down all the time. That's the three major things you look at if you suspect hemolysis. Clinically, look for splenomegaly or lymphadenopathy, be it. And the other important test is the direct Coombs test, looking for antigens on red blood cell surface versus in the plasma.